Hello everyone, today is the last episode of the season 2 and we are going to do a rapid fire revision of the drugs, whether agonists or antagonists, acting upon the different adrenergic receptors. It will be kind of a very useful episode for people who are actually seeking or looking out for quick revision. And that too in a very less time, especially when you are very thorough with the drugs. Speed is very important, and speed is what actually makes the episode more captivating. So without any delay, let's begin the rapid fire revision of the various adrenergic, agonists and antagonistic drugs. Welcome all to IS Pharmacology Difficult Podcast. I'm your host Dr. Radhika Vijay, MBBS MD Pharmacology, and this is the audio hub to get the best simplified basic tips, strategies, methods, and lots of ideas to learn better, understand better, and make your concepts crystal clear. If you really find and if there's a question hovering in your minds, is pharmacology difficult? Lend me your ears for a while and let in the magic of knowledge. Now to begin with, I have first and foremost the drugs that are alpha receptor agonists. I'll be doing in different categories. So to begin with, we are dealing with the alpha receptor agonistic drugs, and in that the first subhead is alpha 1 selective drugs. Well, I'll give you a short list. Phenylephrine, mephentermine, metaraminol, midodrine, and methoxamine. These are the alpha 1 selective agonistic drugs. Their prominent pharmacological action or effect is to cause vasoconstriction, and because of this effect, they can be used clinically in ailments like nasal congestion, postural hypertension. As far as nasal congestion is concerned, they are generally applied topically. The various adverse effects seen with the alpha 1 selective drugs, they are reflex bradycardia, hypertension, dry mouth, sedation. Then again, when they are abruptly withdrawn, there can be cases of rebound hypertension. So I just want to say that other specific points in addition to these most important points, like we can say some note to down points about mephentermine and metaraminol are, they are indirectly acting to release norepinephrine, and midodrine is a prodrug. Next, coming on to the next subhead, that is alpha 2 selective drugs. So as far as the alpha 2 selective drugs are concerned, the short list of the main important drugs, they are clonidine, the most important one. Related to clonidine, we have apraclonidine, guanfacine, guanabin's, brimonidine, then we have alpha methyl dopa. These are the most important ones that we have alpha 2 selective drugs. Coming over to the most important action or effect of these drugs, they decrease the sympathetic outflow from brain to periphery, and that actually leads to decreased peripheral vascular resistance and also decreased blood pressure. That is the final effect. Then they are also decreasing the sympathetic release of the sympathetic transmitters, which are actually released from the nerve. They are also decreasing the production of aqueous humor. So, due to all these effects, how can they be used clinically? Definitely, they have a very good clinical use. They are used in shock as adjuvants or additional drugs. They are used in hypertension. They are also used to decrease the sympathetic response, especially when there is an attempt to withdraw the narcotics, alcohol, tobacco, etc. And because of the aqueous humor reduction effect, they are very useful in glaucoma. Then what else do I have to say about alpha 2 selective drugs? Well, topically we can use clonidine, brimonidine for glaucoma and ocular hypertension. And methyl dopa is basically a prodrug converted to alpha-methyl norepinephrine, which is an effective alpha-2 agonist. So, that was all about alpha-2 selective drugs. Coming over to the indirectly acting alpha receptor agonists. The short list consists of the drugs like amphetamine, methamphetamine, methylphenidate. Now, methylphenidate actually it helps in the release of norepinephrine in the periphery and in the centrally. That is why acting on the central effect is causing the release of serotonin, dopamine, and also norepinephrine. Now, what are the most important effects? Why they are so useful? Because they cause stimulation or activation of the central nervous system. Then they are also increasing the blood pressure, and they also activate or stimulate the myocardium. How can they be used? Where is they used clinically? Definitely in the treatment of attention deficit hyperkinetic disorder. They can be used in narcolepsy. They can be used in the treatment. Very rarely they are employed for the treatment of obesity. And there are definitely very important side effects related to these drugs which are indirectly acting alpha receptor agonists. The most important ones are tremor, insomnia, anxiety, hypertension, tachycardia, arrhythmias of the heart, and restlessness. That's the most important list of the adverse drug effects that I can give to you. Coming over to some additional points or some additional notable things about these drugs, well, they are Schedule 2 drugs. That you need to remember. They are Schedule 2 drugs, and their long-term use can lead to development of tolerance. And chronic use also leads to the development of dependence. When there is some problem or some disease which is underlying in the patient who are administered these drugs, there can be cases of hemorrhagic stroke also. And if they are used for a very long term, they can sometimes result in some kind of paranoid schizophrenia. Okay, so that's all about these indirectly acting alpha receptor agonists. Coming over to the next subhead, mixed acting alpha receptor agonists. So there's a difference. Indirectly acting means they are acting via the release of certain other neurotransmitters, both peripherally and centrally. While mixed acting are like dopamine, which are acting on the receptors like alpha 1, alpha 2, beta 1, D1, and they release norepinephrine. Second important drug in this mixed acting alpha receptor agonist is ephedrine, that is acting on alpha 1, alpha 2, beta 1, beta 2. It also causes the release of norepinephrine. So what is the most important effect of dopamine as far as alpha receptor stimulation is concerned? It causes vasodilatation in a large many places like coronary, renal beds, etc. It increases the glomerular filtration rate and also natriuresis. It can increase the natriuresis. It increases the heart rate and contractility. It also increases the systolic blood pressure. So, by all these effects, where it can be used? Any guesses about it? Well, I'll give you the terms. There are no delays, no more guessing time. So they can be very useful in cardiogenic shock, congestive heart failure, and also in acute renal failure. And if they are used in large doses, then definitely they can lead to some adverse effects like vasoconstriction, restlessness, etc. Additionally, we should know that they are important and very useful because they maintain the renal blood flow, and they are to be administered IV, not any other route. Then we come to let's talk about another mixed acting drug, that is ephedrine, that I already have told you. Its most important effect is similar to epinephrine, but as far as the central nervous system stimulation is concerned, definitely it's a longer lasting stimulation. Coming over to its uses, it is very useful in asthma as a bronchodilator. Then it is also useful in ailments like nasal congestion, and it can be used in the treatment of hypertension and shock. But definitely it has some areas related to it. Ephedrine can cause side effects like tremor, anxiety, tachycardia, insomnia, and hypertension. It can be given by all the routes, and it is not a very commonly used drug. We just keep it for some reserve drug or some additional drug, not a very main drug or very common drug. It's not a very common drug. Then coming over to the next major group of drugs. So in that we have beta receptor agonists. As far as the beta receptor agonists are concerned, there are again many subheads. First of all, I want to talk about the non-selective, that is beta 1 plus beta 2 receptor agonists, which are actually acting on both the receptors. And the most important drug is the isoproterenol. Okay, that is only one drug that we can talk about, which is a kind of a non-selective agonist. Then its effects are like decreased peripheral vascular resistance, increased cardiac output, bronchodilation, and it can find use in asthma as bronchodilator. It can also find use in complete heart block, cardiac arrest, shock, etc. The most important adverse effects related to this isoproterenol, they are tachycardia, tachyarrhythmias, headache, flushed skin, palpitations, and cardiac ischemia in patients which are already suffering from coronary artery disease. Then the basic route of administration is intravenous, and it can also be given via the inhalational route in the patients of asthma. So coming over to the next subheads, we have talked about non-selective. Let's move to selective ones. In that we have the most important, and that is the beta 1 selective. We're talking about the beta 1 selective. The most important one is the dobutamine. Dobutamine is the only and the one most important beta 1 selective drug. It increases the contractility and also the heart rate and also the AV conduction. So where it can be used, definitely in treatment of cardiac decompensation, but that's not a long-term treatment. We can use it only for short-term treatments. It can be given in patients of CHF after surgery and also myocardial infarction after surgery. What are the side effects related to dobutamine? Increased blood pressure and heart rate. They can be really some problematic situations. It can be given only by an intravenous route, and its use should be monitored if the patient is suffering from cardiac arrhythmias or hypertension. Now, coming over to the next most important selective drugs, beta 2 selective drugs. And in that, I'm going to give you the list. There's a little long list. Albuterol, phenoterol, isoiterine, bitalterol, then levalbuterenol, metaproterenol, then terbuterol, procaterol, then we have terbutaline. These are all the intermediate acting. Intermediate, you understand, they are not acting for a very long time, not acting for a very short time, but in between the long and the short time. And their major use is due to their effect. Their effect is the relaxation of the bronchial smooth muscles. Also, the uterine smooth muscles are relaxed, and when they are given systemically, then there is a kind of activation of some other beta 2 receptors also, because they are beta 2 selective, so they can cause beta 2 receptor activation elsewhere also apart from the smooth muscles. And in this way, if they are used, they can find great use in conditions like asthma, COPD, because they can be very good bronchodilators. Then for bronchospasm, they find only short-term use or intermediate-term use. Not a very long-acting, dependable, reliable drug, but yes, definitely it's useful. Coming over to the adverse effects of these long list of drugs. The most important one is muscle tremor, skeletal muscle tremor, then tachycardia or certain other cardiac problems, especially when these drugs are systemically administered. And these problems can be curbed if you give the drug via the inhalational route and not the systemic route. So that is one way to prevent some adverse effects up to some extent. Coming over to the other knowledgeable things about these drugs, their use should be monitored when the patient is suffering from cardiac problems. And again, if you're giving by inhalational route, then the cardiac problems are not a big problem. And they are the drugs with actually the least number of side effects. We cannot say that the side effects are very severe or very fatal. They have the most mild and the minimal number of side effects. In the same list, that is beta 2 selective, we have a subhead also. I talked about the intermediate acting drugs. Now I need to talk about the long acting drugs. And the long acting drugs, we have a little longer list. Not so long, but yes, we have a long list. The most important one, formoterol, then we have salmeterol, then we have arformoterol, then we have carniterol, then we have indacaterol, then we have rhydodrine. These are the most knowable drugs in this whole long-acting beta-2 selective agents. What is their effect? What is their action? Definitely, they call the smooth muscle bronchial, smooth muscle relaxation. Also, the smooth muscle in the uterus is relaxed. So, where they can find their use? Quite similar to the last list, but let us know specifically where they are useful. They are very good bronchodilators in chronic obstructive pulmonary disease, that is abbreviated as capital COPD. Then they are very good to choose drugs in the prophylaxis. Why? Because they are long-acting drugs. So they are very good to choose drugs as far as the prophylactic action is concerned. Then rhydodrine has a specific use. It can really arrest the premature labor. It can really stop it, arrest it, and not very accountable side effects, but side effects to be known are they are actually not very useful in asthma. Like I told you, they are useful in chronic obstructive pulmonary disease, but not very useful. Rather, they are contraindicated in asthma. Just note it down, contraindicated in asthma, and they have a long action and they are favored prophylaxis. Definitely, I've told you all these things. Moving over to the next main head, without any stoppage, we are going to talk about the direct acting non-selective agonists on the adrenergic receptors. Okay, we have done with alpha agonists, we have done with beta agonists. We need to talk about the directly acting non-selective agonists, not the selective ones I'm talking about. So the first one, we have epinephrine. So what is epinephrine? Epinephrine is active on alpha 1, alpha 2, beta 1, beta 2, beta 3. All the receptors it can actually activate and stimulate, and the most important effects, they are heart rate is increased, then blood pressure is increased, contractility is increased, cardiac output is also increased, then due to vasoconstriction, and that is vasoconstriction is an effect that is seen in the viscera, but vasodilatation is the most important effect in the muscles, skeletal muscles I'm talking about. It can also increase the glucose in the blood, in the circulation, and also lactate. The amount of lactate can be enhanced in the circulation. As far as the peripheral vascular resistance is concerned, it can be decreased up to a certain level, not significantly, but yes, it can be decreased. So where is this epinephrine used? In open angle glaucoma. It can be used in anaphylactic shock. You know, it's a drug of choice. It is used in complete heart block, in complete heart stoppage, arrest. It is a good bronchodilator in asthma, especially acute. and it can be combined with local anesthetic agents to prolong their action. Okay, so definitely it has a lot of side effects. The list can be given like cardiac arrhythmias, cerebral hemorrhage, tremors, headache, a lot of anxiety, restlessness, palpitation, all these kind of unwanted, undesirable effects. And these are generally avoided via the oral route, and they are drug of choice in anaphylaxis and very good life-saving drugs in cardiac arrest. You can say that. Coming over to the next important drug, non-selective directly acting agonist. We have norepinephrine. What about the receptor account? Where is it active? It's active on alpha 1, alpha 2. It's active on beta 1 much more than beta 2. So just mind my words, beta 1 much more than beta 2. As far as beta 3 is concerned, no, it's not active on beta 3. Let's move over to the effects. It causes blood pressure increase, both systolic and diastolic. It leads to vasoconstriction. It increases the peripheral vascular resistance, and the heart rate contraction is also increased by direct action, and reflexly the heart rate is decreased. Just mind my words again, reflexly the heart rate is decreased, but directly the heart rate increases. Coming over to its only and one important clinical utility, and that is hypotension. Because it's a very good effective vasoconstrictor, so it's very well used in hypotension, and the most undesirable effect is quite similar to epinephrine, but we can say hypertension, and it is not absorbed orally, so better not give via the oral route. No need, no use, it's all in vain. Coming over to our next most important head, and that is alpha blockers. Alpha blockers, first of all, the subhead is non-selective alpha blockers, and they are actually the classical ones. Phenoxybenzamine, tolazoline. These are the non-selective classical alpha blockers. Their effect is to decrease the peripheral vascular resistance. They also decrease the blood pressure, and they cause the dilatation of the veins, that is venodilatation, where they can be used in the treatment of the excess of the directly acting or other alpha receptor agonists. That is, we can say that excess of catecholamines can be reversed or treated with these alpha blockers, which are non-selective, and such ailments can be pheochromocytoma, but their adverse effects are postural hypertension, failure of ejaculation, important, failure of ejaculation. Then if they cause the activation of the heart muscle, that is cardiac stimulation, there can be certain kind of reflexes which actually cause release of norepinephrine, and that is due to the alpha 2 receptor block. Now, phenoxybenzamine is one of the drugs that can produce a very long-lasting alpha block, and it can also block the neuronal and the extraneuronal uptake of the amides. That's the characteristic of phenoxybenzamine. Coming over to the next drug or the subhead, we have alpha 1 selective blockers. We have a long list: prazosin, terazosin, doxazosine, trimazosine, alfizosine, tamsulosin, silodosin. I'm sure you remember all these drugs. And what is their effect? Decrease the peripheral vascular resistance, decrease the blood pressure, and they can cause the relaxation of the smooth muscles in the urinary bladder, neck, and also they can cause the relaxation of the smooth muscles in the prostate. Well, their major important effect is to treat the primary hypertension, and they can also use to treat the increased urine flow in the benign prostatic hyperplasia. And the most important adverse effect is postural hypertension, especially in the initiation of the therapy, that is when the therapy begins. We can know that prazosin and related quinazolines, they are very selective for alpha 1 receptors, and tamsulosin also is very selective for alpha 1A kind of receptors. Coming over to the beta blockers. As far as beta blockers are concerned, I'm going to talk about the non-selective first, and we have really a long list. And non-selective ones, they are the first generation beta blockers. The list is nadolol, penbuterol, pindolol, propranolol, timolol. The prototype drug is propranolol. It causes a long list of effects. Decreased contractility of the heart, decreased cardiac output, decreased heart rate, decreased conduction in the atria and the AV node, increased refractory period of the AV node, but bronchoconstriction. Then again, decrease in the plasma fatty acids, decreased HDL cholesterol, increased LDL cholesterol. The good cholesterol is decreased, the bad cholesterol is increased. Where it can be used, a long list of clinical ailments where we can employ non-selective beta blockers. There is hypertension, cardiac arrhythmias, congestive heart failure, angina, pheochromocytoma, glaucoma, HOCM, that is hypertrophic obstructive cardiomyopathy, hyperthyroidism, migraine prophylaxis, acute panic symptoms, then substance withdrawal, which are used for the substance abuse withdrawal. Then also they are used in portal hypertension and variceal bleeding. They have a long list of adverse effects. Negative inotropy, decreased cardiac output, bradyarrhythmias, bradycardia, decreased AV conduction, bronchoconstriction, fatigue, a lot of insomnia problems. Then we have nightmares. Then we have hypoglycemia is prolonged or masked, sexual dysfunction in men, and a lot of drug interactions are also seen with non-selective beta blockers. And the effect is directly proportional to the sympathoadrenal tone. Then because they cause bronchoconstriction, they should not be used in asthma and COPD. Then they are of great contraindicated in asthma and COPD. They are contraindicated in diabetics because they prolong the hypoglycemia. Then propranolol and betaxolol have a membrane stabilizing effect. And the pindolol, it also exhibits the intrinsic sympathomimetic activity, which is not very prominent in other drugs. Coming over to the second generation beta blockers, that are beta 1 selective blockers, and their list is acid-butylol, etanolol, bisoprolol, betaxolol, esmolol, and metoprolol. Well, the only difference with the first generation is that they have less side effects. As far as the bronchial constriction is concerned, their side effects are not very prominent. Therapeutic applications I'm not gonna repeat. You can just check out the first generation. Actually, they are same. As far as the side effects are concerned, they are quite same to the first generation, but slightly less in severity to the first generation. Again, we can say that their effect is directly proportional to the sympathoadrenal tone, and bronchoconstriction is less as compared to the non-selective agents, and they should be used with great caution in asthma and COPD. Coming over to the third generation beta blockers that are non-selective, and we have cartiolol, carvedilol, bucindolol, and labetalol. Well, all these receptors, they act on beta receptors also, and they block the other receptors also, especially the alpha one. Their basic use is to use in the treatment of hypertension, and especially carvedilol finds a great use in heart failure also. And additional alpha receptor blockade is seen with labetalol, carvedilol, and bucindolol. They block the alpha 1 adrenergic receptor. Then if you talk about the additional nitric oxide production, it's seen with celiprolol, nebivolol, cartiolol. Then beta 2 agonistic properties are additionally seen with celiprolol, cartiolol, and the calcium channel blocker property is seen with carvedilol. Antioxidant action is also observed in carvedilol. Other things to know about these third generation agents is that vasodilatation is seen, and they act via multiple mechanisms, As far as the intrinsic sympathomimetic activity is concerned, it's very less in labetalol, and receptor polymorphism, it affects the responses, especially in the case of bucindolol. Coming over to the third generation vasodilators. These are beta 1 selective. So third generation vasodilators can be non-selective also, and third generation vasodilators can be beta 1 selective also. There are only two drugs as far as the beta 1 selective third generation vasodilators are concerned, and these are celiprolol and nebivolol. So this was a really long, around half an hour long episode, and I just want to say that I tried to be very clear and not giving too much details, at the same time giving the right amount of details that were actually required to have in the revision. So it's such a big topic. The season 2 whole, we can say it's a crux and summary of the season 2, that is the ANS. But still, ANS is such a vast topic that it cannot be summarized in half an hour. I tried to do so with alpha receptor agonist and antagonist, but at the same time I would just say that for all the details you have to refer to the list, the playlist of all the episodes that we have done so far in season 2. This is just an effort to have a rapid fire revision of these agents without any stoppage or without any delay, which can be actually of some use to those who are revising the drugs and their effects and their utility, their side effects, and some knowledgeable points about these drugs. I hope this episode would be quite useful and you like the episode. Well, now it's officially the end of season 2, and if I gotta add some additional topics, I'm gonna do them under the head of bonus topics and for the season 2 only. But at the same time, I just want to say that we are approaching 12th of December. That is the 3rd birthday of IS Pharmacology Difficult Podcast. I'm going to do a Thanksgiving episode that day for all the listeners, for all the appreciators all around. And finally, wrapping up, I would just say for all the updates and latest episodes of my podcast, please visit www.ispharmacologydifficult.com, where you can also sign up for a free monthly e-newsletter of mine. And that e-newsletter is Pharmacology Further e-newsletter, which is also associated with Pharmacology Further podcast. That contains a lot of updates about medical sciences, drug information, and much more. If you want to see, you can just check out the e-newsletter and the podcast. You can follow me on different social media handles like Twitter, Insta, Facebook, and LinkedIn. They all are with the same name as Pharmacology Difficult. If you're listening for the first time, do subscribe and follow whatever platform you are consuming this episode. Stay tuned. Do rate and review on iTunes, Apple Podcast. Stay safe, stay happy, stay enlightened. Thank you.